So I've been tasked with speaking about upper gastrointestinal problems in TOF OA children. And I wanted to start off really by giving a tribute to a couple of groups. The first tribute is really to all of you. I often get asked, why did I go into pediatrics and why did I do pediatric gastroenterology? How could you work with all of the children are so unwell? And I have to say, it really is down to the bravery of the children and the families that keeps all of us going. So I really wanted to give that tribute to all of you. The second tribute I don't often give is actually to, in fact, to my surgical colleagues who have really taken a very challenging disorder and worked over many decades to improve the outcomes that we really see today. So, so well done. I know that you may think you are God, but actually you do God-like things. Okay, so the plan really for the next 15 minutes or so was to really talk a little bit about the size of the challenge that children with esophageal atresia and TOF face. I wanted to talk a little bit about normal upper gut function, talk about the problems that are encountered, and then touch briefly upon management. I have to apologize for the simplicity of, hopefully the simplicity of the talk that I'll give, but I'm only a gastroenterologist, so so you've already know well, I don't need to tell you about the size of the problem. It's so esophageal atresia, TOF, is the most frequent upper GI malformation. Survival has improved dramatically over the last decades, and we have an increasing number of patients that are surviving. Now, Frederick Gautrand, who's in the audience, kindly gave me this data, which really shows in a similar population the number of patients with surviving with esophageal atresia, which really tells us now that in the equivalent population of the United Kingdom, we have many thousands of people that are surviving with this condition. So looking back over the years, it really tells us two things. Firstly, that esophageal atresia is a significant disorder that accounted for so much mortality in the past, and also that it's a lifelong issue. And no matter what paper I pick up, if you look at data across follow-up data looking at children with esophageal atresia, we see, for example, this study from Denmark showed that they do suffer from significant amounts of upper gastrointestinal problems. So about two-thirds of children have swallowing difficulties, or what we refer to as dysphagia. More than half present with gastroesophageal reflux disease, and that's where you have reflux, which is severe enough to cause other complications. And really, again, half have evidence of inflammation, and half, as you've already heard this morning, or more than half, will suffer from respiratory complications. I know you're also familiar with this patient and parent-focused questionnaire, which really showed that these upper GI symptoms really persist into adulthood. So whether we're talking about reflux, we're talking about dysphagia, then we're again seeing significant numbers which are still continue into adult life. And I guess the bravery thing always gets me in the fact that the quality of life actually reported by families of children with esophageal atresia is never really as bad as we may think it is. And I look after children with many complex disorders, and I think a lot of you actually reset your lives, and your quality of life is now based on a different benchmark than it is. And I suspect that if we really looked at changes that have occurred in your life, then they'll be much more significant than those that are actually reported. Now, apart from upper GI problems, then of course feeding difficulties are significantly common. So this is a nice review by Rachel Rosen from Boston, which she quoted a number of studies which suggested up to about half of children have some abnormalities of feeding. Meal times take long. There's a lot of meal refusal, symptoms during eating, vomiting as well. However, there are surveys out there which suggest that the problem is probably much more common than that. It's not just 50%. It's probably even more than 3/4 of children and young adults will report some sort of issues around feeding. So again, this is going to be a big issue that does persist. Now, the majority of studies suggest that these are secondary to abnormalities of the esophagus, but there's a lot more data which suggests that it may also sit higher up within the initial part of swallowing. I'm not really going to touch upon that. There's not enough time to do that. But we can always discuss that in questions. So I love the gastrointestinal tract. I'm a gastroenterologist, and I think it's the best thing ever. If I look at the esophagus has really an amazing function. It's quite a simple thing if you think about it. It's just a tube. We've had, some of you may be familiar with this because your children would have had to go through esophageal manometry. And this is really a measure of how the esophagus is contracting. And of course, you need this contraction to push food down the esophagus. So this is a pressure plot which shows a swallow within the esophagus. And this is a normal pressure plot. So here we can see this line running here of pressure, which is really what we call the upper esophageal sphincter, sitting at the top of the swallowing tube esophagus. And if you initiate a swallow, and you can see this contraction within the pharynx, you will see it opens a little bit because you'll get the blue, there's a break in the red, and this shows that food is now moving into the esophagus. So now we've got a food which has passed this closed thing, which opened, and then it's gradually moving down the esophagus with these contractions of the esophagus. And it's it's occurring in a very coordinated way because we see this nice slope which is going down. And what needs to happen at the lower esophageal sphincter, which is the closure here, is that it needs to open. And of course you can see here that this bold line breaks, and you get this break with blue in here, which shows that the esophagus at the lower end is now opened, and that's allowed the food to fall within the stomach. So this is what we would call a high pressure plot of your esophageal contraction. Now, if you take somebody with an isolated tracheoesophageal fistula, so in some respects you may view this as the simplest abnormality, where the esophagus appears to be largely normal. Does it look normal? Well, in fact, in a substantial number of children, it actually doesn't. So if you remember the nice plot that I showed you of normality with the contraction moving down, we now see that although the upper sphincter seems to contract and open to allow food to come through, there's nothing going on down below at all. So there's no ability of that body of the esophagus to push anything down. It's not contracting at all, although there is some amount of function of the lower esophageal sphincter. Was it something I said?
Not mine.
All right.
It's not mine.
If you look at more complex disorders of the esophagus, of course, then the abnormalities are likely to be much greater. Now, the figure that I've showed you here is actually before this child had surgery. So this is just showing really how the esophagus is working. And why does this occur? Well, I'll put this very old picture from the mid-1980s, which really explains it. So this is biopsies from the esophagus, looking at nerve cells within the esophagus. This is from normal esophagus. And you can see that all of these nerve cells, there's lots of them sending all their processes out, like in a network. But if you look within the esophagus of a child with esophageal atresia, we see in this case that there's hardly any of these nerve cells at all, and they're not really sending their fibers out. So there's an abnormality of development of the nerves alongside the abnormality in development of the structure. Now, we know lots more about this because people have shown that there may be certain chemicals which are lacking, that the nerves need to talk to each other. There may be abnormalities in smooth muscle or other cells which allow us to contract the esophagus normally. So therefore, it's not surprising if you're thinking about a repair of esophageal atresia that you are bringing two ends of esophagus which have got an abnormality, that eventually when you connect up the esophagus, although it's structurally now looking more normal, that you will continue to have abnormality. So therefore, if you do an esophageal manometry in most children, or I would say probably all of them, they will have some sort of abnormality within the tracing. And again, in this instance, after surgery, we can see again, there's no real contraction occurring within the esophagus at all. The esophageal body is not able to contract. And of course, a child suffering with this will have a swallowing difficulty, will suffer from dysphagia. Now, the second problem that we see is gastroesophageal reflux. We all reflux, all right? Babies, as you know, regurgitate or reflux physiologically all of the time. But we have good mechanisms to protect us against this. We have a complex group of muscles sitting here between the esophagus and the stomach, known as the lower esophageal sphincter, which is helped a little bit by the diaphragm. And then if we do reflux, so for example, if you do get acid going up, we have strong esophageal contractions and secretions which will push the acid back into the stomach where it belongs. So you can imagine, I've just talked about the weak contractions here, and you can imagine that if you had reflux here, that the weaker contractions coming down the esophagus are not really going to be able to drive that acid back down into the stomach, and then you will actually get the contents of the stomach sitting there in contact with the esophagus for a longer period of time. And the other thing is that, of course, as you know, in surgery for esophageal atresia, especially if you have a long gap, you're going to pull up the esophagus, and you will inevitably, no matter how skilled a surgeon you are, you will inevitably disrupt this muscle structure to some degree. There's a higher incidence of part of the stomach passing into the chest, which is known as a hiatus hernia. And we can see now we get a disruption of the strength of this muscle. So not only is the esophagus not so good at pushing things down, but you've lost some of that strength of that valve which stops the acid from going up. And of course, there's much more complex operations which may be needed in especially long gap esophageal atresia, which will disrupt it even more. Now, we also know that, in fact, the commonest cause of reflux for anybody who suffers from reflux is when, even if you have a valve which is normal, it just suddenly decides every now and again just to open. It just relaxes, and these are called transient lower esophageal sphincter relaxations. And we also know from work done by a number of groups that, in fact, in children with esophageal atresia, even these are more common. So you have an esophagus that doesn't contract all that well, you've disrupted the structure at the lever of the sphincter, and also you have more of these relaxations which allow acid to escape back up. What about the stomach? If your stomach worked efficiently and cleared everything moving downwards, then of course you're likely to suffer less from these problems. Now, although we need to know a lot more about this, there are some emerging studies which also suggest that gastric function in children with esophageal atresia or tracheoesophageal fistula may be impaired. So there's studies which have shown that it may just take a much longer time to empty out. And there are also conversely some studies which show that they may pass the contents out too quickly. Now, as far as reflux are concerned, of course, if you get a lot of acid going up into the esophagus, you may suffer from discomfort and pain like heartburn. You may get tissue damage or inflammation. This may also contribute to worsening function of the esophagus or worse problems with swallowing. And of course, you heard about airway compromise as well. Of course, we now know that there are other forms of inflammation that you may see within the esophagus. So there's a type of inflammation known as Eosinophilic Esophagitis, and that appears to be more common. Frederick Gautrand is now initiating a study looking across at this particular condition. And of course, one of the thoughts about recurrent strictures occurring at the site of the anastomosis may be that the continued reflux also contributes to a stricture recurring within the esophagus. And of course, earlier on, you also heard that there may be change. I think you heard about changes within the esophagus. I think somebody was talking about that. And of course, we mustn't forget that in a lot of children with esophageal atresia and tracheoesophageal fistula, they may have other conditions associated. And we know, for example, things like pyloric stenosis and malrotation and abnormalities within the initial bit of the small bowel, the duodenum, may also be affected. So dysphagia, or swallowing difficulties, these are the guidelines that were published very recently from the European Society and North American Societies, where Frederick Gautrand is a co-author. So we always advise that we should look for dysphagia when patients, because little children aren't necessarily going to say, hey, mom, dad, I've got a little bit of a swallowing issue going on here. Well, they may say that. I guess you may say that. But you may see it in food aversion, food impaction, difficulty in swallowing, and a whole host of symptoms which may occur. So you have to have a low threshold about thinking about dysphagia. And we've talked a little bit about the many causes that may give rise to this. Now, it's interesting that if you look at children, even those who don't have symptoms, we now recognize that there's a proportion of children who don't actually seem to have any symptoms at all, but have evidence of inflammation in the esophagus. So therefore, the current guidelines also suggest that even in these asymptomatic children, that we do need to consider routine monitoring of the esophagus to ensure that you're not getting inflammation, even despite the fact that they may not be complaining of anything. And there are a suggestion that this should occur at the age of 1 after stopping their initial anti-acid therapy before the age of 10 years and at the point that they transition on to adult life. Now, of course, this is a stricture within. This is a contrast study showing a stricture sitting within the esophagus. So you can see this narrowing with this stricture. You may see this at endoscopy. And this is not uncommon, so anastomotic strictures can occur fairly frequently, and some studies have been reported to occur in the vast majority of patients that have esophageal atresia. And the new guidelines also suggest a pathway by which we can look after children who have anastomotic stricture, which includes looking carefully at the esophagus, understanding whether there might be another process which is contributing to the development of the stricture that you may be able to address. And then in a very careful way, considering repeat dilatations, making sure that reflux treatment is optimal. And then if you've really addressed all of those and you're having recurrent strictures, then that's the time that you may consider a surgical option such as a fundoplication. So what is a fundoplication? Again, I'm being very simplistic and assuming you don't know, but it's basically just tightening up that lower end of the esophagus. So there are a number of procedures that are used, and essentially this is one of them, where part of the stomach is used to wrap around the lower esophagus. Now, of course, I've just told you at the beginning that the esophagus may not be so good at pushing things down. So there is a risk that when you actually tighten the lower end of the esophagus, the children may have more swallowing difficulty. So you may stop the reflux, but you may increase the swallowing problems that occur. So therefore, advocating a fundoplication is obviously a very carefully considered a process, and therefore there are guidance that we've now given to clinicians about when to consider a fundoplication. For example, if you had recurrent strictures, if you have very poorly controlled reflux disease despite optimizing your medical treatments, if you are dependent on feeding beyond the stomach, and of course if children run into bigger problems such as blue spells. How am I doing for time? 5 minutes, okay. I'm not going to cover this because I think you talked a little bit about this, but we do know that if you recurrently if the esophageal lining gets hit time and time again, then it can begin to show some changes within it. So instead of having a lining which is similar to what we see in skin in the esophagus, it starts to look a little more like the lining of the stomach could look. And the stomach is good at dealing with acid, and that's why the esophagus may choose to go down that path. But of course, it may actually start to become a little bit more abnormal. We know that it's it's commoner than in the general population. It seems to be commoner than children just with reflux. Now, whether or not it actually gives rise to an increased risk of malignancy in the long term, I don't think we absolutely know that at all, and this is part of the reason of having more studies to be able to understand that absolute risk much better. So if I just finish off really by just touching upon the kind of management which many children may be on. So of course the first one is the newborn child who's had a surgical correction. So the current guidance is that in the first year they're much more likely to have problems with gastroesophageal reflux and disease and complications. You're waiting for a lot of healing to occur. There's a lot of growth that needs to occur. So at this moment in time, the recommendation is that they should have effective acid suppression therapy, pretty much all of the children within the first year of life. There's a lot of concerns about the long-term use, and it should be, of using acid suppression therapy. And of course, life is always about balancing risks and benefits. So the suggestion is that they really ought to then have a test to show whether they're refluxing, and there are very clever tests we can use, like pH impedance studies, which you could even do on acid suppression therapy, which look at the movement of contents of the stomach up into the esophagus. And then depending on that, you really go down a pathway of either weaning off your acid suppression if you seem to have grown out of this tendency of reflux, or going down a route where you may actually need to be monitored a little more closely. Then, of course, there's children that are symptomatic. So these are often older children, and they may have more significant feeding problems. There's a low threshold suggestion that you should really assess them carefully, especially if they're symptomatic, because they may have developed strictures, they may have developed other problems. So this is the use of things like endoscopy, using things like contrast studies, making an assessment whether there's inflammation within the esophagus and treating it appropriately. Because of course inflammation is just a description of redness within the esophagus, but understanding why that redness is there really helps you direct your treatment. For example, if you have eosinophilic esophagitis, then you may have a different treatment than if you had pure inflammation which occurred from reflux by itself. And of course, just to finish off, we know that symptoms will persist for the vast majority of patients into adult life. And Stefano has already talked about transition earlier on, and I'm just really hitting home the point that one of the critical things really is about making sure that we have an effective transition. And in fact, the guidance from the guidelines that were published is that we really need to ensure that we're making strides in the pediatric world to ensure that care is optimal, but we also need to ensure that it's really free-flowing, which I'm very confident, having sat down with the rest of the advisory board here. I'm very confident that is something that is definitely going to happen. So just to summarize, well, we know that upper GI problems are very common in children with esophageal atresia and TOF. They carry both short and long-term morbidity and include a host of things which I've talked about. And management really is about being aware, all right? Being aware that you may have asymptomatic children, but you still need to monitor them. Being aware that symptoms may suggest you need to look carefully. Being aware about what kind of treatments you need to stop in. And of course, as usual, anything in medicine, there's not one treatment that's going to fix everyone or treat everyone. It's often a tailored treatment for each child, and careful transition is really a key. I have to thank Frederick, who just walked into the room here for a loan of some of his slides, and I'm grateful for that. I started off by thanking all of you for your commitment and bravery, and the surgeons as well. But of course, it's a much bigger team that's involved. I think it's Professor De Coppi in the front here driving this. But there's a huge number of people in a multidisciplinary team without whom we wouldn't really be able to function together. So I'm grateful, of course, to the whole team and not God himself.